Hello, everyone, and warm welcome to ANT Neuroeducational Webinar Series. My name is Farnoosh. I'm the Head of Education and happy to be moderating today's session, which is about identifying strategies for individualized brain stimulation for major depressive disorder. I'm very happy to see the number of attendees, and they're increasing as I'm speaking. In general, we are very delighted to see the traction of these webinars in the scientific community. Our presenter today is Dr. Juliana Corlier, who received her PhD in cognitive neuroscience from Sorbonne University, Paris, and has completed her postdoctoral training from UCLA Neuromodulation Center under the supervision of Dr. Andrew Luchter. In her current work as an assistant project scientist, she oversees projects that combine neuronavigated TMS, simultaneous EEG, and multimodal neuroimaging, focusing on the development of biomarkers and individualized stimulation approaches to TMS treatment. The session will be followed by a live demonstration of Wiser2 navigated TMS used in therapeutic settings, as well as a short introduction to EEG TMS setup. And that will be presented by Sebastian, who is the product manager for NTMS solutions, and Dr. Antonia Tellen, who is our senior application specialist at ANT. So before we proceed to the session, I'd like to mention a few points. First of all, you see control panel in front of you, and you have a section called questions. Your voice is actually muted by default, but at any time during the session, you are able to send your questions. Only the organizers can see the questions, and during the Q&A session, we will discuss them. I hope for your understanding that we may not be able to answer all of those questions for time limitations, but you're more than welcome to contact Juliana after the webinar and discuss your questions offline. The contact information will be shared toward the end of the session, okay? And another point is that there are a few poll questions to keep the session more interactive. Please participate, and the results will be shown live. Cool. So let's get started. Juliana, thank you for being with us and accepting our invitation. I'll give the screen sharing to you.
Thank you so much. Thank you for the kind introduction. Also, thank you to ANT Neuro for organizing this webinar. I'm very happy to present my work today. Basically, I will talk to you about my work of the past 3 years in the UCLA Neuromodulation Division on identifying strategies to individualize brain stimulation for major depressive disorder. I have performed this work with great support from our physicians and research and clinical team, and also in collaboration with Dr. Linda Carpenter. So after briefly giving you an overview of our research setting, I will present you 3 studies from our laboratory, and then I will finish by summarizing and giving you a brief outlook of the future projects. So the UCLA TMS clinical and research program is really a rather busy clinic with about 6,000 individual treatment sessions per year. Just earlier this year, we have opened a secondary site in addition to our UCLA headquarters, so to speak, in Pasadena. We have several stimulators from McVenture and McStim. Of course, also equipment from ANT Neuro, particularly the 64-channel EEG system and the sensor system for electrode sensitization. Our clinical research focuses on depression, obsessive compulsive disorder, but also tinnitus, pain, and anxiety. But today I'm going to talk just about depression. And really, our overall aim is to include all patients who are referred to us for clinical treatment, also enroll them in research participation, which we usually achieve in about 90% of the cases. So in my first study, I'm going to talk about EEG connectivity changes during the first session to predict rTMS outcome for depression. And before we really dive into the study, let's start with the first poll question. If you could please read it out or display it.
Sure. What is the benefit of predicting treatment outcome? Reduce patient burden, reduce physician burden, find alternative treatment strategies for non-responders, all of the above. You've got 30 seconds to respond, please.
So that is in case you are yourself performing clinical research. I'm just curious, what is to you the greatest value of being able to predict outcome?
Okay, so far 40% of the attendees voted. Let's wait for a few more votes. All right, so let's see the results. So all of the above has 76%.
Great.
Then find alternative treatment strategies for non-responders, and the other two have equal percentage, 3% only.
I mean, obviously, all of those are great. That's exactly the point. But for us, the central question really is the following. We know that if we're stimulating, we're treating 50 patients with, let's say, 10 hertz rTMS to the left dorsolateral prefrontal cortex, there will be a significant proportion of patients. Do you see my mouse?
Yes.
Yes, a significant proportion of patients who will not respond. So to us, the central question is how to catch these non-responders earlier in the treatment and maybe be able to offer them alternative treatments. How do we go about predicting responders from non-responders? There's been a lot of work previously using all kinds of EEG measures or clinical items, but today we're focused on EEG measures. So from spectral power changes to peak frequency or connectivity, cross-frequency coupling by a number of different groups. And the success has been partial, notably due to the difficulty of independently replicating biomarkers. So it is still an ongoing question with a great clinical relevance. In our approach, in this current set of patients, we had about 115 patients, I think. We had a 64-channel resting state EEG with eyes closed during the whole first session, so pre, during, and post the whole first treatment. And then the patients went on to receive 10 hertz treatment at the left dorsolateral prefrontal cortex and for 30 treatment sessions. And our target variable was the connectivity change in the alpha band that we were using to predict final treatment outcome at session 30. We're using the alpha band because the stimulation of 10 hertz falls into the alpha band. So how did we do that? We used a method for prediction that is called elastic net models, and we built these models in the following way. We have used the 64-channel EEG, and we have defined the seed electrodes, as the electrodes around DLPFC and the stimulation site in the left frontal region. All the other electrodes were considered target electrodes, and so we have calculated pairwise connections between the seed and the target electrodes. That gives us a number of connections that is about 1,000 connections, 1,000 pairwise connections, so a quite large number. For all pairwise connections, we have separately calculated 3 different connectivity metrics: coherence, amplitude correlation, and a novel metric we call spectral correlation, which is basically just the similarity of the spectral profile of 2 channels in the alpha range. So it can be quite identical or similar, or somewhat different. So then, using these 3 metrics, we have built separate models for the 3 metrics, using the elastic nets by splitting the whole sample of 113 patients into 70 and 30%. The 70% we're using really to build the model and cross-validate it internally using 10-fold cross-validation, and then the remaining 30% were untouched and were just used for prediction purposes. We repeated this splitting process into 70, 30, 100 times to account for random variability in the subsampling procedure. And afterwards, what we have obtained is a feature selection, which is basically from the 1,000 total features, we obtain just the top 10 features that are most indicative or most contributing to the correct prediction of responders versus non-responders. So for each run of the model, we would have top 10 features or connections, and then we'll repeat that 100 times. So that's that would be the top 10 connections, connectivity links over the whole 100 repetitions. So we obtain basically at the end a topography of the top channels. To evaluate the model performance, we have used the area under the curve, which represents the accuracy of the model. All of the 3 connectivity measures performed quite well, all above 80% accuracy, with the alpha spectral correlation performing slightly best than coherence and amplitude correlation. In terms of topography, it's interesting to see that coherence and amplitude correlation have shown a symmetric frontoparietal connectivity pattern that was associated with response, while for spectral correlation, there was more like a frontotemporal bilateral connectivity increase that was a signature of a successful treatment. So to summarize this study, we can say that changes in EEG connectivity in the first treatment session can represent a successful biomarker for 10 Hz rTMS treatment to the left dorsolateral prefrontal cortex. The topography seems to be to include frontoparietal connections and frontotemporal connections that have to be increased, or that are increased in this population sample. But now the next step would be to source localize these connections to see how they're actually looking in the network level, source localized network level. And obviously, the investigation is not finished here at this point, because there are so many other connectivity metrics that we can still use, and maybe those that we haven't tested yet can even provide better prediction than what we have achieved now. And now my next poll question to you: if in your research you use EEG connectivity measures, what's the most common EEG metric that you prefer using, if any? And that's for me just to have an idea of, preferred methods. If you allow me, I can just go ahead and read the question. So is it magnitude squared coherence, or rather phase coherence, or is it correlation of time series, or like amplitude correlation, or any other metric? So if you have any other, like an open question, feel free maybe to use the chat function, and I can see it later.
Okay, let's give it 20 more seconds.
Sure.
Around 30% voted.
Sure.
All right, here are the results. Phase coherence, 50%, and then correlation of time series, 23%, other, 18%, and magnitude squared coherence, 9%.
Yeah, that's.
Is that what you expected?
That's, I mean, kind of. That's very good to see that, you know, phase coherence is definitely a preferred method because it can avoid spurious volume conduction contamination. So, but for those who responded other, I would also be curious to see what other methods would be interesting. So maybe we can incorporate them in our future investigation. Thank you. So then let's go to the second study. So there are different ways to individualize treatment, right? So you could just thinking of some ways you could increase or individualize the number of stimulation pulses. You could increase or decrease stimulation intensity. You can add or change the stimulation location, and you can also adjust the stimulation frequency. I think you will notice in this talk I'm mostly focusing on the last one, on individualizing stimulation frequency, and the reasoning behind this was the following project. This is actually how we came to appreciate the relevance of the individual stimulation frequency. And notably, we were looking at the relationship between the individual alpha peak frequency, also called the IAF, individual alpha frequency, and clinical outcome with to rTMS in depression. This work has been done in collaboration with Dr. Linda Carpenter from Brown University. There has been previously a number of studies, especially by the Martin Arns group, showing that possibly a higher individual alpha frequency was related to better outcome, but it was not quite conclusive. And we decided to follow up on this finding, but this time focusing on how the endogenous frequency, so the naturally ongoing rhythm in the EEG related to the external frequency, that means the stimulation frequency, and how that would be related to outcome. So there are many different ways to determine the IEF. In our sample of about 150 patients treated at 2 sites, UCLA and Brown University Butler Hospital, we had used baseline EEG recordings, 5 minutes, at least 5 minutes, with eyes closed. We have used, we have determined the IAF at the frontal location F3 electrodes, just because this was where the stimulation site was. We determined IAF as a peak in the power spectrum between 7 and 13 hertz. So here you see a few examples of different patients with their power spectra, and every time there is a vertical blue bar, this is where our algorithm has automatically detected the alpha peak. There was an additional criterion that the peak had to be above a 95% confidence interval of the overall spectrum. So it had to be sufficiently prominent and above some kind of noise level, or the peak would not be detected. For example, in 50% of patients with these criterion, they had no IAF. Like, for example, in these 2 cases, it's either a little too not prominent enough or a little too noisy. So those patients we didn't include in the study. So in the overall pool of 150 patients, we had 3 different treatment groups. One treated at 10 Hertz, dorsolateral prefrontal cortex left, one at 5 Hertz, and one group at sequential bilateral SB. And that means first 10 Hertz to the left, followed by 1 Hertz to the right dorsolateral prefrontal cortex. We looked at 2 metrics, the correlation between the outcome on the y-axis and the IAF, individual alpha frequency, on the x-axis, but we also looked into the outcome and the IAF distance to 10 Hertz. So meaning the distance between the IAF and the stimulation frequency of 10 Hertz. And interestingly, for both the IAF measure, but also the proximity measure, the only group that has shown the significant relationship was the 10 Hertz treatment group. That means that the IAF mattered only for prediction, in terms of prediction, only for those patients that were actually also treated at 10 Hertz in the alpha band frequency. So this finding was actually replicated in an independent study as a first replication project of the ICON-BD. This is the International Consortium on Neuromodulation for Biomarker Discovery. This consortium includes about 9 or so labs worldwide, was recently founded after the last brain stimulation conference. And the purpose of this consortium is really to enable independent replication and larger data sets. So it's a great effort. If you're interested, contact me if you wanted to join this consortium, would be interested in growing. So this study was by the Roloffs et al., the Martin Arns group. They also confirmed that in fact this IAF proximity is only relevant for the patients actually simulated at 10 Hertz. And there we could see the closer IAF matched to the 10 Hertz treatment, to the 10 Hertz treatments frequency, the better the patient performed. So to summarize this study, I can say that a closer match of endogenous, intrinsic, and stimulation frequency probably has, a role for treatment outcome. It seems to be a robust relationship because we were able to replicate this. And now the question is, what about frequencies outside of the alpha band, right? The alpha band is just 8 to 12, 7 to 13, but what about other frequencies? So before I'm going into the question of individualizing stimulation frequency, maybe first just a brainstorming to you with another poll question. So what are the possible neurophysiological effects of matching the endogenous and ongoing EEG frequency and the stimulation frequency? Is it a stronger entrainment of oscillations, or is it a stronger plasticity effect, or maybe it's an overstimulation and seizures, or is it inhibition of endogenous rhythms?
Okay, the poll is ongoing. Let's give it 20 more seconds.
Sure.
Okay, here are the results. Interestingly, the first and second option are more or less equal, 35% and 32%. And then inhibition of endogenous rhythms, 23%, overstimulation, 10%.
Yeah, so I mean, this was, of course, a tricky one. Obviously, all of them could be correct. And to be honest with you, we don't know for sure if we can exclude any of or not. What we do know is something we'll know from the Arnold Tong model, which is basically saying that I I lost my mouse here, basically saying that the stimulation intensity necessary to induce or entrain a certain rhythm in the EEG, ongoing EEG, will depend on the match between the natural rhythm and the stimulation frequency. And the further you're away, the more intensity will be necessary to induce a strong oscillation. This has been shown for the IAF, the individual alpha frequency that is ongoing and then stimulated at a mismatch of 0, plus or minus 1, plus or minus 2, and plus or minus 3, showing that, when the input and response frequencies are perfectly aligned with a moderate intensity, you can elicit a pretty strong entrainment, shown in color here. While if you go away 2 hertz or 3 hertz from this alignment, left to the left to the right, even at the strongest intensity, you may not be able to induce the same level of entrainment. So, but again, what about frequencies beyond the alpha band, right? So in the theoretical work, the Hermann group has simulated data predicting that the response to different stimulation, they have modeled frequencies between 0 and 100 hertz, the response to those would be strongest along the diagonal, which is basically the perfect match between the input and the response frequencies, maybe with some subharmonics. But in fact, there is not an empirical study that would be as systematic as this, and for obvious reason, it's complicated to do. But we are interested in designing an experiment that is, following this strategy. So we want to recreate the parameter space, testing different input frequencies and looking at different response frequencies. Notably, we had to limit the frequency space to 1 to 20 hertz because the effective treatment frequencies for depression that we know are 1 hertz, 5 hertz, 10 hertz, but also 18 hertz, like in the Brainstorming device. So those frequencies are just the ones that we know to be effective. We use a Cambridge electronic design device, seen here, to administer those different frequencies. So we can couple a laptop that would then allow us in an automated way to stimulate the maximum, or to make the maximum device output these random the sequence of frequencies. So specifically what we do in the very first baseline session, we have an interrogation procedure, testing, inputting with certain intervals these different frequencies. And then from study 1, we know that it's not just the local entrainment that is critical for eventual response, but it's rather like a network resonance, right? It's the frontoparietal increase in connectivity that seems to be a signature of response. So we use this connectivity pattern and we rank all the administrated frequencies depending on how well they activated the circuit. And then after that interrogation session, the patients go on to receive their usual 10 hertz treatment. And interestingly enough, if you look at their rank of 10 hertz, so the degree to which the 10 hertz at the interrogation session was able to activate this network, so the higher the better the patients did with the 10 hertz treatment. In just 3 subjects, we were able to collect data that of patients who actually received individualized treatment at frequencies of 12.2, 3.6, and 16. And we see that for all 3 of them, by the end of week 4, they obtain a 40% or larger decrease in depressive symptoms, which is rather encouraging. So to summarize all studies, in the first one, we have seen that changes in EEG connectivity in the first session can represent a successful biomarker for rTMS treatment for depression, but more replication studies are necessary. In the second study, we have shown that the IAF is related to outcome only in the patients that are actually treated at alpha band frequency. So input and response frequencies matter. And then in the third studies, we are trying to align the endogenous and stimulation frequencies to better entrain the circuit that we know is relevant for success, for better outcome. So with the hope to boost response. And obviously all efforts of our future studies are really to design treatments at individualized frequencies that would better entrain the circuit. And that's, still needs a lot of refinement of how we define the circuit, what connectivity measure to use, etc. So there are still many open questions. So